You want to think that, oh, my OBGYN does everything. And it's just not true.
All right. So one of the biggest questions I always get from postpartum women is, what the hell is going on with my bladder? And so the first person I thought of is to talk to my friend, Dr. Rachel Rubin, who I have known since she was in residency, med school, one of those things, a long time. Thank you, Rachel, for coming on the show. I'm excited to have you. You're a mom yourself. You've got how many now?
2, 5, and 3.
Okay, I thought you had one more. I don't know. I gave you an extra kid.
No. My medical practice is my baby. So that's my third child.
Awesome. Well, Rachel is like this massive spokesperson, one for like estrogen and hormones and all good things, but is also really a huge advocate in women's care and men's care as well in the pelvic region. So thanks for coming on. Maybe you can just give us a quick blurb about how you ended up is just, the vagina woman and the hormone woman and all that good stuff.
Yeah. So I'm Dr. Rachel Rubin. I'm a urologist who did a fellowship in sexual medicine, which means I take care of anybody who has a sexual health issue, whether it's pelvic pain, low libido, orgasm, arousal problems, erectile dysfunction, crooked penises, low testosterone, you name it, we take care of it. And it is so amazing because there is a lot of people who have, have issues and a lot of lack of education out there, both from the patient perspective, as well as we do a lot of teaching for providers, because we didn't learn this in medical school. I did not learn this in medical school. It took me going and doing a fellowship, to get the training that I have. And I'm very blessed that I have the training, and I'm very loud and in people's faces to get people to understand how little we know about genitals and sexual health anatomy and physiology. And so it's really fun, just like you do so much teaching about just the basic anatomy and physiology of what happens in pregnancy, which is, gosh, you'd think we would have figured out by now, since people have been having babies for quite a few years. And it's infuriating about how little we know, but it's also inspiring because we have so much work to do. And so it really gets me out of bed in the morning and keeps me kind of hopeful because we've got so much work to do.
Yeah. And I mean, it's always awesome as a provider when you have someone in training be like, hey, can I come spend time with you? And that's how we met. And then I've gotten to see your career rocket, and you just opened your practice this year in Rockville, right?
Yeah. So it's a great story, right? In my residency, we didn't get any exposure to pelvic floor physical therapy. Now, that was in 2012. It's been a few years since then, but it hasn't gotten much better. There are no required, rotations where you go and work with a pelvic floor physical therapy. Since you left Georgetown, I don't even think there is anyone in the actual hospital. They actually do less pelvic floor physical therapy in 2022 than they did in 2012. That's insanity, right? It's insane. It's getting worse. And so I just literally, I didn't know who you were. I literally walked over to the physical therapy department. I said, is there anyone here I can shadow? And we met, and I still remember being in that room and learning from you and watching you do, do what you do. And that was foundational in my understanding of this and my ability to then, work in a multidisciplinary way, which is why, again, you and I work so well together with patients, and we need the mental health professionals and a lot of other different providers, because it's not one person that is responsible for sexual health or that fixes sexual health. It's a team. And so sometimes you need a few team members to get it just right for you. And in pregnancy, you want to think that, oh, my OBGYN does everything. And it's just not true. And they don't necessarily get the training to do everything. And so give them a break. They got a lot of things that they have to know and figure out. And they should need other team members to kind of help maximize your quality of life.
Definitely. Now you have like this super interest in hormones. I'm wondering if you can unpack for us a little bit some of the questions that moms have, because we're taught in pregnancy that, we have this huge, massive rush of hormones, and then postpartum, obviously with breastfeeding, moms definitely have some discomfort with sex. We're also told that everything is basically like relaxin, you can blame everything for. So if you could unpack the whole hormone situation, that would be awesome.
Okay, I'll do it all. Let me unpack it all. No, I can't do all of it, but what I can say is numbers are actually pretty helpful. And I think numbers help explain a little bit of the story so people can sort of understand what's going on in their body. So when you are a baby, you have a baby girl has no estrogen in her body. So she's got a vulva that is teeny tiny. She has no labia minora. Her vulva is red, raw, and irritated. She is peeing in her diaper all the time. It is not a place you could put a tampon right? It's a tiny little teeny area. That's no hormones. That is no estrogen, no testosterone. Then that little baby becomes a teenager and she starts to get real mean to you. I know you haven't gotten there quite yet.
We're getting closer.
You're getting closer. My 5-year-old is already being very teenage-like. So
Yes.
I don't know how I can handle it. But as that teenage years come on and the hormones increase, the body literally morphs and changes. You grow labia minora. The tissue becomes pink and stretchy and lubricated. It becomes a fertile place, right? And so that is hormones that does that. Then, okay, so then you have hormones, you've got your period. And so depending on where you are in your cycle, your estrogen ranges from like 50 at its lowest to maybe like 150 or to 300. That's kind of where it kind of cycles, where the ups and the downs go. Well, when you get pregnant, your estrogen goes to 3,000, right? It gets really, really high. I can't tell you what progesterone numbers get to. I'd have to look that one up, but that's that relaxin idea. And yes, progesterone can kind of cause, they think, some loose ligaments and loose areas, but does it explain everything that's going on in pregnancy? No, definitely not. Now, estrogen goes to about 3,000. Well, then you give birth to the melon and it comes either out of your vagina or your abdomen. And by the way, if you have a knee replacement, you get physical therapy like 3 times a week. My mother-in-law had a knee replacement during the height of the pandemic, and a physical therapist was paid by Medicare to go to her house 3 times a week. And yet when you have a watermelon come out of your vagina or your abdomen, no one talks about physical therapy. In fact, you have to beg to get a referral to physical therapy. It's insanity, as you know, and all of your people listening already know I'm preaching to the choir. So you give birth and your hormones completely crash. You get this surge of prolactin, which is what allows the breast milk to come in, and that shuts off the ovaries to no longer produce estrogen and testosterone. In that state, you are menopausal, right? Essentially, it's a menopause-like state because you're not producing hormones. So from going to having an estrogen between 50 and 300 when you're having your periods, and then to go to an estrogen level of 3,000 when you're pregnant, to now having an estrogen of zero. And guess what happens when you have an estrogen of 0? Remember that baby we just talked about? Dryness, irritation, bladder leakage, muscles aren't necessarily going to be as strong. And then you're told that you should breastfeed now up to 2 years, which, don't get me wrong, breastfeed for as long as you like. It is your decision.
I heard that.
But understand that breastfeeding will affect the health of the vulvar, vaginal, bladder, and urethra tissues. It's very hormone sensitive tissue. And so that's what breastfeeding does. It's a menopause-like state because evolution says, let's focus on this baby before we go making another
Don't have
one.
any more, right?
Right? It tells you, like, oh, honey, this is why your libido is low. This is why your libido is low. Honey, leave me alone because I'm literally feeding this human right here. So if you don't have a libido, it's not because your partner's not gorgeous. It's not because you don't have a great relationship. It's not because you haven't slept in 5 days. Well, it is that too. But this idea that you have no hormones in your body, and the idea sexual health is very biologically driven. Yes, it's also psychosocially driven. It's all of the above. And so while you're breastfeeding, you're in a menopause-like state. This is why people over 50 and every decade past 50, 60, 80, 90, you have a lot of women will have dryness, irritation, urinary tract infections, leakage, pain with intercourse, and it's all a hormonal issue. Now, as everyone listening knows, and Carrie Pagliano isn't responsible for, there's muscles under that tissue. So if that tissue is thin and irritable and doesn't feel good, all of those pelvic muscles underneath, if you see above my head, if you're watching the video, there's a lot of muscles in this pelvis. They don't like being in pain and they don't like the dryness, and they tighten and they squeeze, or they don't respond like happy muscles when they're surrounded by unhealthy hormonal tissue. And so that's where the synergy comes in of getting the hormones corrected and getting the physical therapy muscles corrected. Now you can still breastfeed. You can have the best of both worlds. You could use a local vaginal hormone, that will not affect your milk supply. It will not affect your periods coming back. It will not do whole body hormones, but you can put a small tablet or a cream in the vagina. I like the tablets better than the cream, honestly, and it can help soak that tissue in the hormones that it needs so that you don't have the dryness or the pain or the irritation. Now, everyone's different. Some people get their periods back while they're breastfeeding and they don't notice the dryness or the pain. Some people are very sensitive to the hormone changes, but it's not universal. So your best friend may didn't have that problem, or your mom maybe didn't have that problem. So you feel very alone. You said, oh, I can't talk about this. And most people don't go back to the gynecologist after that 6-week visit. And at 6 weeks, you're just still trying to figure out what is the floor, is the sky up or down? I don't even know.
Yeah.
And so women don't realize that they have to put on their oxygen masks first. And sometimes you have to make that extra appointment to go see the doctor and say, hey, everything's fine with the baby. Thank God, everything's fine with this. But, it is kind of uncomfortable down there. Unfortunately, not all doctors are educated to know that there are very safe and effective treatment methods. So they just tell you to use lubricant and just have more sex. God, my OBGYN told me to have more sex, that more sex would fix the problem. I said, do you know what I do for a living?
Right. You're like, do you know who you're talking to?
I was very upset when I left that visit. So I was like, do you know how it works? Like, really? That's not how it works. So does that make sense?
It does. I mean, I think that the biggest question I have, and I've been really lucky to be exposed to you for a long time, is knowing when, gosh, you would really benefit from hormones, and having moms like they don't even know how to start that conversation with their provider. And if their provider is saying something like, oh, well, just wait until after you stop breastfeeding, or, oh, this should just get better with time, or, oh, use more lubricant, and they're kind of dismissed. Like, how do you advocate for yourself knowing that information is out there and knowing kind of what you need?
It's very difficult. And that's why I never stop working, meaning from the moment I'm on Instagram or Twitter or teaching doctor courses or teaching patients, because it is those patient advocates who says, oh, hey, I just listened to the podcast. You have to hear this, and how beneficial that can be for then the patients advocating for themselves. And sometimes you have to see a couple different and it's frustrating. Some doctors are very open to learning new things. Some doctors are very open to hearing about this, but some aren't. And do you want that kind of doctor who's not even open to having the conversation? And it is your body, your choice. You get to advocate for your own body and what you do with it. And that being said, local hormones have never hurt a fly, right? They're super safe. They're super effective. And the problem is a lack of education that all hormones are not the same thing. And so most gynecologists would happily start a birth control pill while you're breastfeeding.
Yes.
And that's like a nuclear bomb amount of hormones compared to a local vaginal hormone. So it becomes tunnel vision. And a lot of people are not that good at looking at the big picture and kind of treating, which issue is going on. Does that make sense?
So what do we say to kind of help moms who are like, all right, we know that most moms, when they're going in for that postpartum visit, they're going to get the check for depression. They're going to make sure that there's no bleeding and no, massive, disruption of organs flying out or things like that. And they're going to get thrown on birth control. And like, can you do birth control and local hormones, or do they kind of counter each other, or what happens there?
There's no danger or harm, but we do need more research in does it help? Because sometimes an oral birth control pill can create a menopause-like state for the vulva. Right. And so some women who take a birth control pill get vulvar pain. You take them off the pill, you add back a little hormone, and they do quite well. But not every gynecologist is aware of that issue.
Right.
So if you take a birth control pill, if you added a local vaginal hormone, it may help. It likely will help. I love IUDs, for many reasons, but IUDs don't typically cause this issue. And so, we gotta have the conversations. And so I wish at that 6-week visit, I almost wish you would go back at the 8 or 12-week mark, get your physical therapy referral, get your vaginal hormone, and have a conversation of get a mirror. That's my perfect visit. Get a mirror, look at your new vulva because it has changed, right? You had a watermelon come out of there potentially.
Yeah.
Look at it, introduce yourself to it. Look, what's your labia, what's your clitoris, what's your vestibule, what's your vagina. Look at it, appreciate it now that it gave birth to this amazing human, right? And then understand how that will affect you sexually, how we can improve the hormone status, how you can improve the muscle strength, go to physical therapy. That would be the most amazing postpartum visit in the world.
The guided tour. I mean, because that's the thing. A lot of women, they never looked before. And then they look after, don't know what they're looking at. And I find kind of one of two things. One, well, actually, it's probably one of three. One, they won't look at all. Or there's one and they'll look and they're like, oh, okay, fine. And then there's the third that they look and they're like, what in God's name is that? They're totally freaked out. Now they're on high alert. If there was any overactivity, it's definitely primed up now. It's if you don't have that guided tour of the anatomy, because like my talk from my mom, I love you, mom, but like it literally was, got on the pill and she's like, that won't prevent STDs, right? Like that was my sex talk.
Yeah.
I was like,
It's bad, right? It's really bad. And so
I love you, mom.
we love you, mom. It's, and it's, so in fact, I had a patient in my office just yesterday who the first thing she said to me, she said, Dr. Rubin, you could make an entire career and change your whole practice and just see teenagers. And I want
Oh
you to,
my
and she said, I
gosh.
want you to do that. And I said, she said, it doesn't have to be you, but can you bring someone into the practice? Because how amazing would it be as you go through puberty and you have a doctor who gives you a mirror and gives you a tour and say, this is your labia majora, this is your labia
Yeah.
minora, this is your clitoris, this is your vulva, this is your vagina. Give words early. I'm a big believer. I wish the pediatrician would start doing that
I
and
know.
say, this is your foot, this is your elbow, this is your vulva, this is your penis. Like we
Yep.
need the words, because if you have words, then well, if something hurts or something doesn't feel right, it's not just this
Absolutely.
strange mystical area that is supposed to give you orgasms. Like
Right.
you should know what is what and where things are coming from.
Right. But even I think at an early age to have that conversation beyond just the basic anatomy, but just to talk about these hormones, like how many women don't realize that we need testosterone, we have it, and we're taught, in basic biology, oh, that's a boy's thing, and it's not. And then the first conversation that we have postpartum, like I remember getting my IUD after my second, and like I feel like I'm not an idiot, but I don't remember having the conversation where we agreed to do the IUD, and a couple years later I'm like, I don't want this thing anymore. I don't even remember how I got there, because you're having conversations when you're incredibly vulnerable.
If you follow me on Instagram, and it's at Dr. Rachel Rubin, I have a video where I was like, I have a pants rule, right? Everybody wears pants when nobody makes good
Yes.
decisions with no pants on. So we are going to talk when you have pants on. We're going to examine you, and then you're going to put pants back on, and we're going to talk. If you're wearing a skirt, it's fine. But we have that rule because you do. And that was, again, I learned that rule when I was a patient. I was in this tiny gown waiting for 45 minutes for the doctor to show up, and then they come in and they leave, and you're very vulnerable, and you just feel awful, and you're cold, and you're mad at the world, and you don't hear what people say. Right. And so I actually love virtual visits because
me too.
I love doing virtual visits because then the patient is in their own house with their own cup of coffee in their own space, and it is incredibly amazing for sexual health visits because they feel so much less vulnerable. They'll tell you things, and then they'll come in for the exam, and they'll come in, ready to go. I think it's magical kind of to do it that way.
No, I think so too. Talk to me a little bit about, you mentioned a little bit earlier, hormones and urinary tract and that sort of thing. And I don't think people connect those things. We think about, hormones in the context of like puberty and pregnancy and breastfeeding, but I don't think anybody really has a sense of what's going on with the urinary system.
Yeah, gosh, I yell at urologists on a daily basis because we were not taught about that, and that urologists must be comfortable with hormones. And so thank God, because I'm yelling and screaming, the American Urologic Association has agreed to do a guideline in genitourinary syndrome of menopause. So understanding the hormonal relationships with the bladder. This has been my dream. This is my advocacy work to get urologists to give a crap about hormones and how the hormones affect the bladder and the urethra. We give too many antibiotics that aren't needed. We're not preventing the problem. We are causing major damage by not treating people with local hormones. And so the urethra and the bladder, as well as the vagina and the opening to the vulva, are rich in both estrogen receptors as well as testosterone receptors, like you said. And we barely talk about the estrogen receptors, let alone the testosterone receptors. And so as you lose those things, right, as your ovaries shut down, whether from breastfeeding temporarily or from menopause or from surgical menopause, if you have your ovaries taken out, you lose the hormones that are circulating in your body. And without it, the tissue thins, it gets raw, it gets irritated. It actually loses its acidity. The vagina specifically loses its acidity, so it can't fight infection. So women develop bacterial vaginosis or a microbiome that just isn't working the same way that it used to. Gosh, the dryness, the wiping is kind of hurting. It hurts to sit. I can't wear those tight pants anymore, Dr. Rubin. I have urinary frequency, urgency. I wake up in the middle of the night all the time to go pee. I can't go play mahjong with my girlfriends anymore because I'm going to have to pee too many times on the way to my friend's house. And so I've changed my life or I have to wear irritating pads because I'm going to leak all the time. And now my vulva is irritated all the time. It is all a hormonal issue. It is all hormonal, and it's bladder hormones. The problem is, and I had this, a guy, an oncologist, a cancer doctor called me this week. Lovely guy. He called me, he was so sweet. He said, Dr. Rubin, I'm seeing one of your patients who is on vaginal DHEA, which is a vaginal insert that has a DHEA, which is a precursor to estrogen and testosterone. He said she uses this for a little bit of vaginal dryness. Is it, I don't know much about this. I'm learning. I'm a new oncologist. He was very open-minded. And I said to him, I said, thank you for calling me. You're an amazing doctor because you're interested in learning about this. I said, listen to me. You got to change your tone here, because vaginal dryness indicates a small problem. This woman was divorced. She got breast cancer very early, and her husband was abusive and horrible, and actually left her because she had such horrible pain, couldn't have intercourse, had all these urinary problems, had chronic pain issues because of what the breast cancer medications did to her bladder, her urethra, and her vulva. I said, this isn't a little vaginal dryness. This is life and death. I mean, she had horrible, husband left her. We gave her this vaginal DHEA, and she was she has this wonderful boyfriend and a wonderful, sexual health life, and she can sleep and she can urinate. And it was life-saving for this woman. I was like, that's very different than vaginal dryness.
Yes.
Which is how it is often taught to doctors.
Well, and that brings up a really good question, because I remember distinctly. I mean, I'm mid 40s. My mom now is like mid 70s. I very much remember that era, probably when I first went into PT, where all the hormone replacement therapy, they're like, oh no, bad breast cancer history. And my grandmother may or may not have, it was the 60s, God only knows. And so I think there's a whole generation of us that our mothers were taught, no, HRT, it's bad. Any local hormones, if you have, unpack that piece of it, because I know that's a recent debunking as well.
It's, so hormones are not all the same, right? An IUD is not the same as a birth control pill. We get that. Hormones in menopause are not all the same. And so there was a big study that came out in the early 2000s. We could do a whole podcast on that study, and we should, because it's very interesting politics, where the NIH spent $1 billion trying to look at whole body hormones in menopause. And it was a disaster of a study. It was not very well done. And then it was marketed in a way that actually wasn't based on what the data actually showed. And so basically there was all this misinformation that came out about it. And overnight, everyone was like, Matt Lauer got on the Today Show and said, everyone throw out their hormones. This is the worst thing you could ever do for your body. It was before the paper had even been published. So the doctors couldn't even have a chance to read what actually happened. And we haven't been able to come back from it since. 20 years later, we're still getting people to understand. So you have a whole generation of doctors who are not taught how to do hormone therapy, why to do hormone therapy. And so there are a few of us out there who still know how to do it. And there are newer ways to do it that are so much less dangerous, even though what they did probably wasn't that dangerous. But even how we do it now is so different, and it's much less dangerous, and the data is so much better. And people won't even give women the opportunity or the chance to make evidence-based risk and benefit risk conversations, which is a disaster, right? If your doctor says, oh, you don't want hormones, those are dangerous, and they think all hormones are the same, find a doctor who actually knows what they're talking about.
Yeah. Well, and I think just for people to be aware, and I don't know that, being in the medical field, I think it's commonplace to understand that things are constantly changing. But I think if not, you're just hung up on, hey, this is what was 20 years ago. This is what's ingrained in your head, and you don't even know to ask. You don't even know to think to ask.
You don't know what you don't know. I talked to a billionaire yesterday who was like, gosh, I'm 50 and I've got I just have been sick since April, and all these things are going on, and I just don't feel good. And I literally had to say, and this was someone who I know is knowledgeable about this space. And it was like, could it be perimenopause?
I know.
And she was like, holy crap, it's it was like this light bulb. She's gotten her thyroid looked at, and she's got this and that looked at, and I listened to all of her symptoms. I said, I think this is just perimenopause, and I think we can fix it. And it was like this moment. And so if even billionaires are not getting good advice, how can anyone? So we're doing a group menopause clinic. Actually, we have 2 of them scheduled. I think there's some space in our September group where people can just come and learn about menopause for 2 hours and then get a customized visit where they get, kind of one-on-one attention as well. But there needs to be more, just like in PACE groups for pregnancy, we need some community around menopause to realize that there's so much misinformation, because also like I'm booking new patients into November, just like you.
Right.
Like
it takes a long time.
We're busy.
Yep.
And so and it takes a long time. So my magic is that I spend time with people and I really explain the pros and the cons and the story, and I get to know people. So I can't see more patients a day, because then it doesn't work with what I do. So I'm trying to do kind of a group visit, as a way to get more information out there. We'll see if it works, but that's kind of my dream, my newest dream.
Well, I think, and again, your kids are a little bit younger than mine, but I think us evolving as providers and as moms, we really see where the gaps are. And I start having conversations with my clients, even when they're like, all right, well, we might have one more kid, or are we done? Kind of what's that look like? Because the conversations we need to prepare them for are next step perimenopause. And I don't know when the hell, it's coming. I'm 46 now. But the other thing too is thinking about, menopause-induced osteoporosis, all of those things, getting workouts under load, like just the things that are going to have to change and shift. But whenever I have a client that they think, oh my gosh, I got off scot-free, never had any urinary issues after baby, and then all of a sudden, they're at SoulCycle, they hop up off the saddle to cycle, and all of a sudden they have a leak and think, what the hell? My first question is, where are we on peri? So
it hits them like a ton of bricks, because nobody warns you, and it happens. It can happen at 35. It can happen at 45. It can happen at 55.
Yeah.
And so many women are like, why did no one warn me? Why was no one talking about this? And it's subtle.
Exactly.
It can start with anxiety. It can start with like insomnia. It can start with like, holy shit, what is this? Sorry, excuse my language. What is this called again? I swear I used to know the name of this thing. Oh, it's a pen. I've got that.
And these days it's like, okay, is it peri, or is the fact that I've been raising two kids in a pandemic for 2.5 years? Because it's kind of the same.
It is kind of the same, but that's what's also hard is you go see the doctor, and the doctor says, oh, you're stressed. Oh, like,
which I have two big middle fingers
up. Really hard during pandemic, which is all true. But I ache for the women who have perimenopause and menopause during the COVID, because no one's picking up on it, and they are suffering at home by themselves, and they are miserable, and they think there are no solutions, but there are really good solutions. And I just talked to a reporter today who she said, oh, wow, you see so many different kinds of patients. It looks like you're doing a lot of menopause. And I said, no, I said, I do a lot of menopause because it's the most fun and the easiest piece of my practice, because I throw a little bit of evidence-based, therapy at these patients, and they do amazing. Like they do incredible. They're easy, and easy's fun.
You got to get easy every once in a while.
And so it's nice to mix the easy with the very challenging pelvic pain. I see a lot of very intense, weird, and wacky conditions that not a lot of people take care of, but I got to mix it in with the easy ones. But I do a lot of teaching, because you shouldn't have to see someone like me to get good menopause care. But unfortunately, it's not often out there.
How can is there any testing that women can go through or ask for to be like, hey, where are we in this train?
No, that's the frustrating thing. People will offer it to you, and they will say, do this saliva test, and it costs thousands of dollars. So I believe in lab testing. I'm a little bit rogue, because the guidance is you don't really need lab testing. If you're having symptoms, we can treat you. I like labs that look at a snapshot of what's going on, but we'll remember I said your estrogen goes from 50 to 300 when you're cycling. When you're in perimenopause, you cycle much bigger and wider, and it's actually the falls in your cycle that hurt, that do hot flashes and brain fog and all these things. So when I get lab work, I don't know if I'm catching you here.
You don't know where you are.
I don't know where you are. So unless we had, and I wish Theranos wasn't a snake oil salesman, and actually we had the labs where you could do a pinprick of blood every day and we could kind of look at it, that would be revolutionary. At this point in 2022, we do not have perfect testing to say, oh, you're 2 years away, you're 1 year away. But if you're having symptoms, even if you're still cycling, you still might be in perimenopause.
Gotcha.
And there are things we can do about it, right? What typically, I don't let your floor go to 0. So if you're cycling and you go up to 300 and then you go straight down to 0, I sometimes give you a little estrogen so that maybe we keep you at 50, so that you go from 300 to 50 instead of 300 to 0. Because
not off the cliff so much.
You don't go off the cliff. There's like a trampoline there, which you may leak, because once you have babies, sometimes you leak with trampolines, but at least it doesn't hurt.
I call that the holy grail of pelvic floor. Like if you can treat that and if you can get that fixed, you're definitely, you've reached the holy grail. Awesome. For you, to circle back and wrap up here, for you as a mom, um, knowing what you knew going in and now being kind of on the other side of it, one, was it what you expected? And two, what would be advice that you would give to an active mom or an active soon to be mom kind of looking at a postpartum part of her life?
It's a very good question. And I'll probably start crying if I actually think about it and talk about it. And I would say, take care of yourself because nobody else will. You are taking care of everybody, and you always want, and I'm a big doctor who says, do what I say, not what I do.
Yeah.
I did not take care of myself the same way I want to take care of my patients. And you have to take care of yourself, not just for you, but because you want your children to see someone who takes care of themselves. And they're watching, your kids are watching how you behave and what you put up with and what you want for you. And that's what they're going to want for themselves. And so I would say, take the maternity leave. Don't kill yourself. Don't kill yourself of every last drop of breast milk. Fed is best, right? You need to be healthy to have healthy children. And so do the pelvic floor physical therapy. Always do the pelvic floor physical therapy. And just give yourself a break. And also, the one thing I would say is, I didn't do this enough, is celebrate your wins. You created a human life. Like, celebrate every single gosh darn win. If you breastfed for one day and you're happy with it, celebrate it. Don't get focused on the stress and the anxiety, and focus on the joy and the life and the incredibleness. We don't do that enough in life. And we get a lot of the stress and the anxiety. And so just celebrate everything that happens in every moment, because I didn't, and I regret it.
Yeah. Well, thank you. Well, and congratulations on your third child. Your practice, my practice is my third child too. So I understand
I will say, you inspired me in every step of the way,
Oh,
and you're a few years ahead of me in this journey. And I can't tell you how much it means to me to see a strong woman make it work and do it. And I was watching you every step of the way, taking notes, and
thank you.
it gave me the courage to do it myself. And so you are an inspiration.
Oh, thank you. As you well know, I think the inspiration is those people that need us, and you're willing to do whatever. And here we are. So, well, thank you. If you want to connect with Rachel, she's on Instagram, Dr. Rachel Rubin. If you have questions on hormones, hop in her DMs. If you're in the DC metro area, she has her practice in Rockville, Maryland. Thank you so much, my friend. I appreciate you and all that you're doing for everybody out there. Thanks again.
Thanks for having me.